So, good evening. We have a couple of questions today, exactly 6 questions to address. The questions that have been asked from me on my YouTube community page. And without much ado, because we are doing it on a daily basis, let's straight away go to the questions and address them one by one. The questions are 6 in number. The first question is, Doctor, what to expect before, during, and after a hair transplant? Well, this is a very broad-based question, and I will only cut it down into a brief synopsis of what to expect before, during, and after a hair transplant. In yesterday's live session, I discussed in detail what all you need to ensure, what are the do's and don'ts before a hair transplant procedure. So you can go through yesterday's live session. It's been recorded. It's a recorded session, and it's available on the channel under the tab live. Okay. And today, now we will discuss during the procedure. What happens during the procedure? So the one day before you come for a consultation, and we planned the hairline, done your tests, and then you go back to your room, think over what was discussed, whether the hairline that was discussed is well suited. You have discussed it with your wife or your partner or with your parents or with your friends. And what do they say about it? Of course, it has to be within the purview of an appropriate hairline, because without that, it will look very improper and the doctor is not going to do your procedure. If you insist on a very low hairline, which is unnatural, because once the hairline is done, once the dye is cast, there's no going back. It's a surgical procedure. We all know that. So in the morning of the procedure, we go through the hairline, which was already designed one day before. The pictures are available, printouts are available, and we see if it has to be tweaked a bit up or down, or the temples have to be closed in. And also discuss with the patient his priority, where would he like to place the grafts, what he gives importance to, and then also discuss various other factors about any doubts that he has in his mind, his family has in mind. And then I proceed to take the patient for trimming of the hair, which I do myself, because I need to see the quality of the hair and whether we will get sufficient grafts from the scalp donor, and the best opportunity is to feel the hair while trimming at a certain length, because after that they're going to be all very shortly trimmed, that is less than 1 millimeter in size. So that is the time when you feel the hair and you see where to place more grafts, the play of light and shadow, so that you can strategically place the grafts. And as we discussed yesterday, grafts are limited in number. And if there is an extensive baldness, we have to strategically place these grafts. We cannot place the grafts randomly or in the same density all over. So we have to use our judgment as doctors with years of experience of how many grafts in which location will give the patient the greatest illusion of density. And then we proceed forward to clean the scalp, which the nurses do. Sterile cleaning is done with betadine and saline solution. And these are winters here, so we heat the saline solution before washing the head. Otherwise, it will be very, very cold. And then the patient goes into the operation theater. His IV line is started, which is very important. No surgical procedure in India can be done without an IV line in place. Nothing happens, but for one in a million case, if something happens, you have a secure IV line in which to give the medication. So the patient is secured. Antibiotic, after giving antibiotic sensitive test, is given, and then the patient is explained the procedure, how the whole day will proceed, how the anesthesia will be given, what is the position that he will keep maintaining throughout the day, when will he be given the first break, when will he be given the second break, that's the lunch break, and when the procedure will be over, which differs from person to person. So then I make the solution, the anesthesia solution, and then mark the donor area, the safe donor area, which is different for different people. If very few grafts are being done, then the donor area will be a little different. If many grafts are to be harvested, then the donor area is slightly different. And then I give anesthesia. While giving anesthesia, most of the patients are very comfortable. We use very small needles, and we use pressure, we use cold temperature, and we use vibration to distract the patient from the needles, the penetration of the needles, which as it is quite well tolerated by patients. Because I'm talking to the patients about them and they respond, and without wincing, they respond. So I assume that patients do not have much pain. And since I have also undergone hair transplant twice, so I know how to relate with pain. It is not much. If anesthesia is given properly, it's nothing much. And then I proceed to do the harvesting. Typically for 3,500 grafts, we will take about an hour and a half to harvest. The grafts are not extracted because ours is the in vivo preservation technique, only punched code and left in place and covered by a wet, saline wet, ASL, PRP solution soaked gauze over the grafts which are still in the body. They are still attached to the body by a thin, flimsy tissue at the base, through which they derive their blood supply. So the grafts are not out of the body, and this decreases the out of body ischemia time, and this is called my Anagen Q plus in vivo preservation technique, rapid harvest. And then after the grafts are harvested, we turn the patient in face up position, and if the beard transplant is to be done, I will clean the beard area and give the anesthesia, and then give the patient a break of about 15 minutes where he goes to the washroom. He has a coffee and a sandwich, and after 15 minutes he comes back, and the beard area, donor area is usually numb, and then I proceed to do the harvesting of the beard grafts. Usually we harvest about 800 to 1,000, 1,200 grafts of the shadow area of the beard, and that takes about 45 minutes. And once that is done, bandage is secured, and then the hairline, which was already marked in the morning, is just traced out, made a little bit more prominent with indentations. Micro and macro irregularities are being planned because a hairline it should not be straight. So we have to give micro and macro irregularities. And then I proceed, after the anesthesia is given, I proceed to make the slits. Single hair in the front, and behind the transition zone, double and multi-hair grafts. Along the temple points, single hair grafts are preferred, and behind the single hair grafts, we can put at the most 2 hair grafts, conforming with the how natural hair are distributed over the scalp. So this is the slit making, following which the plantation is started. My expert nurses, they've been with me for over 10 years, and they know how to do plantation very well, and we have been getting cases. We have been getting good review from patients about the results that they get over so many years. So my whole team is so well oiled that we do not have to tell them what to do next. We use the implanter pen, an implanter pen that I have devised myself for placement, and the placement takes about an hour and a half to 2 hours in 3,500 grafts. And as we go into the placement of the grafts, we harvest them from the donor area, and they go under the microscope for cleaning, for division of the extra skin, and then they're loaded into implanter pens and placed in the pre-made slits. So once the front area is done, we might, if it's an extensive area and it's 130 or 2, once the front, that's a hairline, the temple points, and the mid-scalp is done, we give the patient usually a break for lunch, say around 130 to about, say 150, about 20 minutes break we give them. And then the plantation in the crown area is done, which is done over a bench, which is a wooden bench. And then the patient waits for about half an hour after this is over, has a coffee. We tell him about the cleaning process, change the bandage, wet his grafts, put a cap and give him medicine and send him home. The driver leaves him to the hotel, or if he's local, he can drive. Somebody else may drive him back home, usually a relative. And the next day he will come again around 10 o'clock for about an hour. We'll remove all his bandages, clean up the site, explain him to the care for the next 2 weeks, how to shampoo in the morning and how to shampoo in the evening, what is our protocol for 2 weeks. And then after 2 weeks are over, the crusting has come off. Then what medications are to be taken for 6 months and how often the patient should follow up online with us. So that is the first question, rather long rant on what to expect before, during, and after the hair transplant. And then we come to how do you design the hairline. See, I do not use any laser device because I feel that the hairline has to be little asymmetrical, because beauty is in asymmetry. Both the sides of the hairline are equal and symmetrical only in one racial group, not in South Asians, not in Caucasians, not in Arabs, not in any other racial group. So I design the hairline myself and discuss it with the patient. How the hairline is designed: the hairline should be not in keeping with the patient's age at the present, say 25. We have to see what is the family history of baldness. If we design the hairline very low and the patient balds extensively and there are no grafts left, and we've committed all the grafts by giving him a low hairline, not very low hairline, but an age-appropriate hairline at 25, we will fall short of grafts in the future. So a lot of things make us decide on how much the temple points are to be done and where the hairline is to be situated, depending upon what is the quality of grafts available and how much we predict the baldness will progress. Signs of baldness are evident many times in a 25-year-old, and also by taking history of his family about baldness, we know whether he'll be heading towards extensive baldness or not, and also whether the patient is going to be compliant to medication. Because if he isn't, the native hair are going to disappear very fast and baldness will progress very fast. And a low hairline does not conform, does not go with extensive baldness. It will look fake after some time. It will leave only one option to shave off the head. So how do we place the hairline? See, a patient should, as he ages, grow into his hairline, not grow out of his hairline if it is very low. It will look very ugly, very unaesthetic, unappealing, and the patient is going to blame you for not having advised him in his best interests, because he was young, he doesn't know. He just wants to copy the hairline of his friends and his colleagues and his film stars and the sports people who are his heroes. So therefore, it has to be very carefully thought of where to place the hairline. So we follow the 3/3 from the chin to the base of the nose, and from this nose tip to between the two eyebrows, that is the glabellar point, and from the glabellar point to the hairline. These are the face is divided into equal thirds. And otherwise, if you want to, as a layperson, think where the hairline should be, so it should be above the eyebrows, 4 finger spaces, 4 finger widths. Another way to find out is the vertical vector and the horizontal vector, where they meet and where you subtend the angle towards the skull, is where the hairline should be. And this is how we design the hairline. There are several factors, and much of it is also come from experience. What hairline will suit a particular face: a long face, a broad face, a square face, an oblong face. So this all comes with practice and with experience, and we do keep the patient in picture what sort of hairline he would like to. Many times patients bring their old pictures. We do not benefit in any way by old pictures when he wasn't balding. Now he's balding, so we have to place the hairline accordingly. And then we come on to the next question: a hair transplant in early 20s, is it safe? Well, if you do not have any family history, if it is a very small area that the hairline has receded and the whole head is thick with hair, including the top of the head and including the back of the head. And if the patient is suffering from only sick pattern traction alopecia, where there's no androgenic alopecia, we feel that there is no hint of androgenic alopecia, yes, we can do a hairline restoration as early as 23 years of age. But if there is an evidence that the patient will go into androgenic alopecia at a later date, we postpone the hair transplant to the age of 25 or even 27 years of age. So hair transplant should not be done before 25 years of age if you have androgenic alopecia gene in the family. But many patients will insist, and if the doctor gets convinced, and if the doctor does not have a case for the day, it has been seen that the patient may be taken up for surgery. So you have to be very careful and not get into false promises made by a clinic, which is not very ethical in its approach. You think over it. There's so much of material available online today, how to get a hair transplant done, when to get it done, what errors, what mistakes you should not do during while planning a hair transplant. So next we go on to the other question, that is, does wearing a hat cause hair loss? Yes, if you're wearing a hat which is made of synthetic material, it is going to generate static electricity, and this static electricity is going to pull out your hair. The hair which would otherwise have fallen off in due course according to the hair cycle was going into the telogen phase, will go into the telogen phase faster. The poor quality hair which is miniaturizing will get detached from the scalp, and with the result that your total volume on the hair will become less. This also happens after a hair transplant. If you continue to wear a cap more often than is advised, and if you wear a synthetic cap, you wear a beanie which is made of wool, static electricity is going to break your hair, and your results are going to appear at a later date, not within 6 to 9 months. As the hair appears, it's broken up or detached from the scalp magnetically due to these static electricity currents. So it's better not to wear a hat as long as possible. Now, why do cheap hair transplants, doctor? Why can they be dangerous? Well, there's nothing against cheap hair transplants. A clinic has to figure out its revenue. It has to figure out how much cost goes into a hair transplant and how much the clinic will be saving, because the clinic also has to pay the staff, and nobody gets staff which is permanent staff at low pay. Permanent staff which has been with the clinic for a long time will need to be paid much more, almost double or 3 times the payment that is given to itinerant teams which roam around doing hair transplants. It is very important to have a team which is permanent with you, because they are in tune with your process of hair transplant. You cannot have a new team every now and then. So money goes into this. And then money goes into various processes of sterilization. If you are going to continue to use the same punch, the same needle, and the same implanter pen, see the diseases like viral diseases like HIV, HCV, hepatitis B, so many other viral diseases that we don't even know of are not very uncommon. In the local blood donation center in Chandigarh, I came to know from a friend who's heading the department that 1 out of 20 people have a suspicion of HIV. So imagine a clinic which is lowering the rates but doing more cases with less staff. It is only your imagination. Where will they save the money from? They're going to save the money from improper sterilization, low paid staff which does not know how to sterilize their hands. The results will vary because it's not a permanent staff. The result will be as good as a team which came and did the plantation. And then many clinics which do cheap hair transplants, the doctor just cannot do the hair transplant procedure himself because he cannot do it in 5 patients who are there. Because it is impossible to run a clinic in which you do only 1 case in a day, a cheap hair transplant. It is impossible to run a clinic. So the cost factor is tuned to the safety that you get from a procedure, the skill that you get from the procedure, the reliability you get, and the assurance of a good hair transplant, and also a follow-up which lasts a long time by the doctor who's done your procedure, because only he knows how he has done the procedure, what was the condition of your donor area, and he remembers how your donor area is going to progress because he's done the history taking. Imagine a person who comes to you just for a day and you don't see his face again. Whom are you going to ask what you should do in the next 6 months, in the next 1 year, in the next 2 years? The doctor who's not doing your procedures is not interested in a hair transplant. He's just interested in the revenue. He's just calling people on itinerant basis to do the hair transplant because it gives him additional revenue for his hospital. So that brings us to the next question, last question: hair loss in men versus hair loss in women. See, hair loss in men is mostly androgenic alopecia, and even you do not have to do any test to diagnose it because it's staring you at your face. It's symmetrical. The donor area is spared, and there is thinning over the head or baldness, which is symmetrical. It is a pattern, therefore it is called male pattern baldness, because there is a very clear-cut pattern which is typical of androgenic alopecia. In females, on the other hand, most of the cases of hair thinning, hair loss are hormonal in nature. Hormonal, even male pattern baldness is hormonal, but this is not hormonal based on androgen hormones. This is based on thyroid. It's based on PCOS, polycystic ovarian syndrome or disease. It's based on anemia, which is very common in ladies in India. It is based on low ferritin values, and a host of other things which are not genetic. Whereas in men, it is purely genetic. So this is the difference between men and women. Women require very little grafts, and therefore we do not have to shave the whole head, and the donor area also does not show because we part the hair up and down, and only from the center a stripe of hair is trimmed, and we take grafts from there. So in men, we may like to trim the whole head, but in women we plant the hair because they will not permit us also. We plant the hair in existing hair. So that these are the differences, and these are the 6 questions that I've covered. If you have any other questions that you would like to ask me in the next session tomorrow, please leave a comment in the comment section below, or WhatsApp me on the numbers provided in the description, or mail me at drbhatti@darlingwords.com. The email is also mentioned below. And I hope you like these questions, and we will see you tomorrow. Have a nice good evening and have a nice night. Bye, take care, and God bless you.